بسم الله الرحمن الرحيم. محاضرتنا لهذا اليوم عن الشقيقة أو الصداع النصفي. Our lecture today is about migraine. It is a very common disorder, widely distributed all over the world. I will start with some background information. Migraine is episodic headache, usually unilateral, moderate to severe in intensity, throbbing or palpating in nature, and usually associated with nausea, vomiting, and sensitivity to light. Doctors can usually distinguish migraine from the other two common types of headache, which are cluster headache and tension headaches, by its characteristic. Cluster headache are usually excruciating, sharp, steady pain, while tension headaches are dull pain with persisting tightening feeling in the head. So history is very important to discriminate between these common types of headaches. The WHO estimates the prevalence of migraine around the world, and they found that it is about 10%, which is considered as a high percentage. Migraine is a familiar disorder, so it is hereditary, وراثي, so it can pass from one generation to another. The prevalence in female is more than in male. It's about 2 to 3 times more in female than in male. And migraine is very widely variable in intensity, frequency, and duration. And you will hear different stories from different patients about their migraine course, symptoms, intensity, duration, because it is very widely variable. Pathogenesis, or the theories behind migraine. The exact cause of migraine is unknown, but these are the main theories that stand behind the appearance of migraine. First, we have vascular theory. So it is stated that there is a vasoconstriction of the intracranial blood vessels, maybe meningeal or cerebral blood vessels, maybe both or others. So it is unclear if it is the main cause of causing migraine, the vasoconstriction of intracranial blood vessels. Second, it has been also stated that it may be because decreased serotonin level in the blood. Other theory is neurogenic theory. So they stated that there are some overactive nerve cells that send out signals that trigger sensory cranial nerves, which in turn stimulate the release of mediators like serotonin, substance P, nitric oxide, and calcitonin G related peptide, CGRP. This CGRP is released during the acute attack and has been identified as a possible target for the treatment of migraine. Its receptors have been found in many brain areas, nerve endings, blood vessels. Therefore, its antagonist is useful for treatment of migraine, especially for those contraindicated for the triptan family. I will discuss with you later on in this lecture that triptan family is the main drug or the treatment of choice for patients, except for those with angina or stroke or MI. So if the patient is already with coronary heart disease, or if there is any contraindication for triptan, we can use these GCRP antibodies to treat their migraines. So the fourth and the last theory is that calcitonin gene related peptide has been associated with migraine. So we have vascular theory, we have serotonin theory, we have a neurogenic theory, and lastly we have a promising result regarding the usage of calcitonin gene related peptide antibodies, and I will explain this to you later on in this lecture. Migraine has two main types. First, common migraine or without aura, and this is occur in 85% of patients. Second, classic migraine, which is with aura, and this is happen in 15% of patients. Aura is a term that describes the sensory or neurological changes before the starting point of the headache. Aura mostly originated in the occipital or sensory cortex and presented in different aspects, so it can be visual, sensory, and or causing speech, hearing, motor disturbances, and it is mostly to be occur from 20 to 40 minutes before the headache begins. So it is symptoms or experience that the patient feel before the appearance of the actual headache of migraine. And we depend on this aura to classify the two main types of migraine, either common migraine, which is without aura, or the classic migraine, which is with aura. Some scientists study migraine in details, and they divided it into many stages: prodrome, aura, migraine attack itself, and the postdrome. هذه الصورة للاطلاع فقط، غير مطالبين بالتفاصيل اللي موجودة فيها، فقط للي يحب يطلع على الأعراض اللي تصيب مرضى الشقيقة أو الصداع النصفي. Prodrome, it is a medical term. It is a warning phase that marks the start of migraine, followed by aura, which is about 5 to 60 minutes. Then the attack itself of migraine, the headache, the throbbing headache, then the postdrome. هذه الصورة للاطلاع فقط. What are the triggers of migraine? There are many factors appear to increase the incidence or speed up the appearance of migraine in patients, in specific patients. These are maybe psychological factors like stress, exertion, anger, anxiety, maybe hormonal changes or the usage of contraceptive pills, maybe food, for example hunger, food allergies, and food containing vasoactive amines, and maybe the environmental factor. So if there is a loud noise, bright light, strong smells, even the changes in the weather outside can all precipitate the appearance of migraine. So there are many different and wide variety of factors considered as triggers for migraine. How can we diagnose migraine? Full history and complete physical examination is crucial. It is very important that you have details in history and the examination, in addition to the neurological assessment as well. But sometimes some neurological tests might be ordered to exclude organic causes. It is important to mention that the patient should be involved and informed through all the process and all the stages of diagnosis, of treatment of migraine. So detailed discussions about the findings, the strategies, treatment plan should be carried out at all time between the doctor and the patient. Management of migraine. It is either non-pharmacological or pharmacotherapy. Non-pharmacological العلاج بدون الأدوية. It include avoid triggers, which I have already mentioned in the previous slide. You can use meditation اللي هي العلاج بالتدبر والتفكر والتأمل مثلا اليوغا. And we can also apply psychotherapy. العلاج النفسي مهم أيضا. Regarding pharmacotherapy, it is either a proper treatment or preventive therapy as a prophylaxis, العلاج الوقائي. Regarding preventive therapy, there are several lines available, and can be used as a prophylactic medication, including beta blockers, calcium channel blockers, tricyclic antidepressants, selective serotonin reuptake inhibitors, and recently the calcitonin gene-related peptide monoclonal antibodies. The first two groups, the beta blockers and the calcium channel blockers, we are going to have details about these two families of drugs in the antihypertensive medications lecture in the future, inshallah. Regarding the tricyclic antidepressant and the selective serotonin reuptake inhibitor, we already have a full information about these two groups or these two families in the previous lectures. And at the end of this lecture, I'm going to show you the application of the calcitonin gene peptide monoclonal antibodies. All of these lines are used as a preventive therapy or a prophylaxis for migraine. Now, the drugs that are used to treat migraines are either non-specific or specific treatment. Regarding non-specific treatment, we have analgesics and antiemetics. For example, non-steroidal anti-inflammatory drugs, aspirin, paracetamol, and metoclopramide. Analgesics inhibit the release of prostaglandins, kinin, due to neurogenic inflammation. In addition, antiemetics, for example, metoclopramide, beside being antiemetic, it enhances the absorption of the analgesics itself. So this is considered as a non-specific treatment. Specific migraine treatment include ergot alkaloids, 5-hydroxytryptamine agonists, and calcitonin gene-related peptide monoclonal antibodies. So we have at least 3 main families to treat specifically migraine. They are ergot alkaloids, 5-hydroxytryptamine agonist, and CGRP monoclonal antibodies. Ergot alkaloids include ergotamine, dihydroergotamine, and the bromocriptine. These are the main members, but we have also another members. It is not mentioned in here. Regarding bromocriptine, it is a potent agonist at dopamine receptors and used mainly for Parkinson's disease. So for the main of this picture, I'm going to discuss ergotamine and dihydroergotamine. 5-hydroxytryptamine agonist, they are a large family member, include sumatriptan, naratriptan, zolmitriptan, etc. Regarding monoclonal antibodies against calcitonin G-related peptide, we have calcinzumab, iptinzumab, fremanzumab, and erenumab. Ergot alkaloids. Ergot alkaloids are produced by a fungus. There are at least 20 naturally occurring members of this family and a few semi-synthetic derivatives. هذه معلومات عامة عن عائلة الأرغوت alkaloids. The most important drug that is used for migraine within this family is ergotamine. Is a partial agonist at 5-hydroxytryptamine receptors. It is 5-hydroxytryptamine 1A partial agonist and agonist at alpha adrenoceptors. So it is involved in the vasoconstriction of all peripheral blood vessels. Ergotamine has been a mainstay of acute migraine attack treatment, and it is recommended to be used in combination with caffeine, with coffee for example, as it increases its absorption and thereby its effectiveness. Another use for ergotamine outside migraine is for a postpartum bleeding. It is very efficient, very potent in stopping menorrhagia after labor, and it can be given orally, sublingually, rectally, or nasally. The most common side effects of ergotamine are diarrhea, nausea, vomiting. A very important adverse effect is that if you give an overdose, this can cause ischemia and gangrene that are preceded by paresthesia in hands or feet. This is a very serious complication of an overdose. It will cause paresthesia in the extremities, followed by ischemia and even gangrene. Therefore, it must be used with special care. The most consistently effective antidote for such condition, if it developed, if you notice this in the patient, you should give him immediately nitroprusside. It is a vasodilator. So, as expected, this ergotamine is contraindicated in peripheral and coronary blood vessel diseases. Dihydroergotamine is a semi-synthetic derivative of ergotamine. It is administered as a nasal spray or injection. Nausea is a very common side effect in addition to dizziness and diarrhea. Triptan family, as I mentioned, there are a lot of members within this family. The most important one is somatriptan. Is a 5-hydroxytryptamine 1D, 1B serotonin receptor agonist. It is activating the receptors in the CNS and thereby constricting blood vessels and blocking the release of the inflammatory neurotransmitters. It is the first line of choice to treat migraine. It is preferable to ergot because of lower toxicity and its effectiveness in 80% of patients. It can be given parenterally, nasally, or orally. It can be also used to treat cluster headache. The drug has a short duration of action of about 2 to 4 hours and generally well tolerated. Adverse effects are malaise, fatigue, dizziness, vertigo, and sedation. However, the most important adverse effects are feelings of chest pressure or tightness in about 5% of cases. These may be accompanied by cardiac arrhythmia or myocardial infarction and appear to be due to coronary artery spasm. Therefore, patients with ischemic heart disease, for example, unstable angina or previous myocardial infarction, should not be given somatriptan. In addition, the concomitant use or the parallel use of somatriptan and ergotamine is very dangerous. You should be careful about combining these two drugs together at the same time because both of them causing peripheral artery vasoconstrictions. Zolmitriptan, very similar to somatriptan, but it is only available as an oral preparation and the duration of action is much more longer, of 2 to 27 hours. Calcitonin gene-related peptide is a protein that inflamed the nerve endings and involved in the development of migraine. So antagonism of this pathway is effective for both acute and chronic treatment and as well as for prevention of migraine. Those monoclonal antibodies target either the protein itself, for example, eptinezumab, fremanezumab, and galcanezumab, or act against the receptor, for example, the erinomab. And at the end, all of them are effectively prevent migraine attacks. These calcitonin gene-related peptide monoclonal antibodies have a long half-life. Therefore, they have a long duration of action, which allows them to be used once or twice monthly. They should be given parenterally, and the most frequent adverse effects are pain at the site of the injection and muscle cramps. Upper respiratory tract infection or nasopharyngitis is the most frequent reported adverse effects so far. These antibodies are contraindicated in patients with a history of serious hypersensitivity to drugs. These antibodies consider as a replacement for sumatriptan in case the patient have any coronary artery diseases. We can use this antibody safely when the patient are contraindicated to have sumatriptan or ergotamine. هذه نهاية المحاضرة وشكرا جزيلا.